Good afternoon, everyone. Assalamu alaikum.
Good afternoon, Key. Yes, okay, your slides are on here now.
Okay.
Thank you very much, Key.
Yeah. Hi, Tariq and Sanya. Yeah, this is incredible. Thank you first for allowing me to call in. I really wanted to be there, but I just couldn't make it. I've been following the meeting from here on the Zoom. It's been a remarkable meeting so far. So anyway, Tariq already has set the stage why we needed these recommendations. Just a little background. I used to teach neurosurgery in Ethiopia and also in Cambodia. And I came to the realization that the problem wasn't more neurosurgeons. It was a system level problem. And then the reason the systems are so bad in the first place is politics. And Sanya, I'm sure, knows very well about this overall global health issue and the role of politics. But now we have an opportunity to provide recommendations to policymakers to scale up neurosurgical care throughout their entire countries. And then this body of work represents a set of recommendations that are aimed at the ministries of health if they did choose to prioritize head injuries and spine injuries. I just want to point out a couple of background information. We have a website now called globalneurosurgery.org. The WFNS is now coordinating all global neurosurgery activity. I'm honored to be one of the co-chairs. And in this website, you can find sort of the missions and the mission statements and the objectives. We're on Twitter, Global Neurosurge, and also I'm on Twitter. And I just wanted to start off with what is global neurosurgery. And I want to emphasize that it is the practice. It's a practice of neurosurgery. And we have a purpose. And the purpose is to deliver timely, safe, and affordable neurosurgical care. And here's the key word, to all who need it. It's really about universal coverage, neurosurgical coverage. So let me see here. How do I get this thing to the next? Okay. So the research from our group, we identified that up to 5 million neurosurgical operations are currently unmet. And in order to perform these operations, there's currently a workforce gap of 23,000 neurosurgeons. And as you can see in the heat map, most of those gaps are in sub-Saharan Africa and Southeast Asia. So the policy recommendations were developed, as Tariq mentioned. It was at World Federation, Northwest University, Medical University, and then Programming Global Surgery and Social Change. And it was a combined effort. And we had, Tariq and I were co-leads, and we had a group of people who advised us, gave us comments towards the end. And they are from all different parts of the world and different types of specialties. We had Amos Sadaleya from Nigeria, Andres Rubiano, Franco Servadai, Lugna, who will be talking just, I believe right after me. She's a pediatric surgeon. And so we had a variety of people comment on this. And then we had a team that I was working with, a technical team who put all this together. They did countless literature reviews and systematic reviews. So what was our vision? Our vision is that no person should experience undue disability or death due to head and spine injuries, regardless of where they live. And we chose head injuries and spine injuries because there was the highest, this was the bucket that was the most largest bucket of the 5 million cases that was unmet. It was more than half of that. And we also thought that if we're able to build up neurosurgical capacity using neurotrauma as a base, then within a year or two, these neurosurgical centers and facilities can start doing small tumors, some spine cases, and then it serves as a platform for a more robust neurosurgical facility down the line. But you got to start somewhere, and we felt that trauma was the way to go. And our aim was to develop system-level policy recommendations for reduction of death and disability from spine and brain and spine injury, and specifically geared towards the developing world. So how do we do this? We wanted to keep it simple, right? Because the more complicated we get, it's difficult for policymakers to grasp. So we want to keep it simple. And then we wanted to make it very easy to integrate. So these countries, as Tariq mentioned, even Pakistan, they're developing a national strategic plan for scaling up surgical care. We wanted to use the same framework so that that all you have to do is overlay these recommendations on the framework, so it's easy for the policymakers to conceptualize and to integrate. It's like when we share files, right? You use the same platform. It's easy to combine. So how do we do this? So the National Surgical Plans uses the framework that WHO uses for building blocks of a health system. Infrastructure, this includes things like the buildings, facilities, blood supply, referral systems. Workforce is pretty self-explanatory. Service delivery. How do you optimize the delivery of services through referral service, efficiencies and quality and safety? Financing is a very important part. Information management, and then lastly, governance. You have to have a strong governance structure for the health system to work properly. Then we looked at the trauma, head and spine trauma, the care spectrum. And I remember someone else was talking about prevention. We absolutely have to talk about prevention in these injuries. That's the most cost-effective ways to reduce this burden. So we started off with national surveillance, prevention, emergency care, the pre-hospital care, how to bring the patients to the facilities, then the surgical system, all the way to rehabilitation. And then we just created a grid, a matrix like this. And I know I said keep it simple, and it is, to me, it's simple, and it's a massive grid. And what this does is actually identifies questions that comes up. For instance, what are the workforce requirements for pre-hospital care? What are the financing requirements for rehabilitation? And then we dug through the literature and we try to come up with, as close as we can, evidence-based recommendations for each one of these blocks. And I'm not gonna go through all of them because you can download the entire recommendations online, but I'm just gonna highlight some of these. So let's look at surveillance. We know that some of these countries don't have a complete electronic computerized health data system. So they're gonna have to come up with some innovative ways to collect data and develop national surveillance. Everybody has cell phones. I mean, cell phones could be a good way to capture this information. We also recommended using trauma registries, and specifically, we're recommending the one that WHO, the emergency care program has come up with, because it's new, it is adjustable. We can add neurotrauma data elements to it, and it's sort of become the standard for trauma registries. And then we emphasize the fact that this surveillance is a governmental responsibility, and we want the ministries to completely buy into this. Let's look at prevention. Many times some countries don't even have comprehensive mandatory helmet laws, believe it or not. So we think first and foremost, you must have good legislation, good laws, but that needs to be followed by very, very rigorous enforcement. In Cambodia, the laws were in the books. Enforcement was very poor. Helmet compliance rate was under 20%. And then the key issue there is enforcement. And of course, it's common sense, but well-designed and safe roads should be part of prevention. Let's look at hospital care. Not every country will be able to have a helicopter system, an ambulance, within 10, 15 minutes of any place of injury. So it has to be contextualized, but they have to develop a system. And then they have to also train medical personnel who understands what head injuries, what kind of care head injured patients require and spine injured patients require. And we also found out that the time from injury to neurotrauma facility does not have to be within an hour or even 2. Using data from Cambodia, we saw that up to 4 hours, the outcome after head injury remained about the same. And after 4 hours, the outcome started to get worse. So we believe, obviously earlier the better, but you may have up to 4 hours to bring in a head injured patient to the facility. Surgical system, as I mentioned, the 4-hour window. Once again, this is not a recommendation that you should take up to 4 hours. It should be no more than 4 hours, right? And we came up with a workforce recommendation of at least one neurosurgeon per 200,000 people that will be performing neurotrauma care. And we all that the neurotrauma services should be part of the overall universal health coverage package. And then last but not the least, rehabilitation. We know as clinicians that we can do the best operation, but if we don't have good rehabilitation, the outcome falls far below what we expect. And we believe that the ministry should invest in a proper rehabilitation system that includes physical space and equipment, people trained, and then a monitoring system to show that a data collection system to continue to collect outcome information using this rehabilitation. So I put this watch there because it signifies time is now. Why is that? We have a resolution from 2015, emergency essential surgical care, strengthening of surgical care as a part of a component of UHC. There was recently in the last May, another resolution that was passed for emergency care. So there's a high level global governance buy-in by member states in the importance of strengthening surgical care. More recently at the at the UN General Assembly in September, just 2-3 months ago, there was a high-level meeting on universal health coverage. For the first time, the language of surgical care made it into this declaration where 190 heads of state signed on to this. So there we have, the stars are lining up. We have 4 countries that have now finished their national surgical plans. We're trying to get the Peshwar recommendations into these plans. But there are right now, to my last count, 40 additional countries that are now in various stages of developing national strategic plans for scaling up surgery, obstetrics, and anesthesia. So we have to have these recommendations. We want to put it on the table of these ministry people and make sure that neurosurgical care, as they're scaling up surgical care, is absolutely included so that no one, no matter where they live, does not have an access to a proper neurosurgical care, especially when we're starting with neurotrauma conditions. So I'll stop there. Thank you very much.
Thank you very much, Key, for giving a very good presentation on the whole